So the COVID-19 pandemic is to help them mitigate the impact of COVID-19 on HIV programs, to help them strengthen their health systems, and to help them respond to COVID-19. So we have put in place a specific funding mechanism to do that. And as we speak, we have deployed more than $4 billion to more than 120 countries to help them respond to COVID-19 and protect the programs against HIV, TB, and malaria against the impact of the new pandemic, to more than 120 countries to help them respond to COVID-19 and protect the programs against HIV, TB, and malaria against the impact of the new pandemic. Yes, so as I said, the impact has been really devastating, both directly, but importantly, indirectly, because COVID-19 has completely disrupted health systems. It has disrupted all the other health programs and disrupted the entire economies and societies. So obviously, the African continent is heavily impacted. And what we see is that it is suffering from the inequity in terms of the distribution of the tools to help them confront COVID-19, whether the access to vaccines, which remains obviously extremely inequitable, but also access to the equally important other tools, such as protective equipment for the health workers, diagnostics, oxygen, or treatments. And this inequity makes the continent obviously more vulnerable to COVID for its own population, particularly the poorest and the most vulnerable, but also most vulnerable to the emergence of new variants, as we are seeing today. So at the moment, we are deploying, as I said, the $4 billion additional dollars that we've received from our donors to support countries in their response. So they are using these additional resources to boost their HIV, TB, and malaria programs, adapting them, scaling up some innovations that are proving quite effective. Also using such additional resources to protect the health workers with protective equipments, to distribute diagnostics, both PCR and antigen RDTs, and also oxygen and other treatments. These are all the ways by which they use their additional resources to respond to COVID. They're also strengthening their laboratory capacities, which are proving absolutely critical in the case of the identification of new variants, as we are seeing. In the future, what we are looking at in terms of the Global Fund support to Africa, but also to all the countries we support around the world, is really to help them catch up, because all the fight against HIV, TB, and malaria has gone sort of backwards as a result of COVID-19, and therefore they will need additional resources, but also additional collaboration and innovation for them to catch up. Secondly, we continue to support them fight COVID-19 because it's not over, and it's very clear now that it's not over, and we need a more robust, equitable response. And we are doing that as part of our participation in the ACT Accelerator, which provides a global, coordinated, equitable, end-to-end response to COVID-19. And finally, we will also look at leveraging our capacities, our network, our expertise to help the world be better prepared for future pandemics that might come in the subsequent years. The European Union is indeed a very key partner to the Global Fund. Indeed, the European Commission is our 7th largest donor, and if you add up the European Union member states, that represents around half of our budget altogether. The European Union has been increasing their support to the Global Fund throughout the years. This has been a constant and steady both political and financial support to us. The EC has not contributed to our COVID-19 response, at least as of yet, but they are obviously a key partner in the ACT Accelerator, and pushing for a coordinated and more equitable response globally. What we know is that HIV represented an absolute catastrophe. 40 years ago and 20 years ago, before the Global Fund was created, it was literally disseminating lives, but also economies and societies entirely, particularly in Africa. And in 20 years, thanks to political leadership, activism, global solidarity, we've reduced the number of deaths related to HIV by 65%. So that shows what global solidarity and coordination can achieve. We are not there yet in terms of ending HIV as a global health threat, and this is our goal for 2030, and a lot still needs to be done. It still has a devastating impact on societies and economies in the countries where it's most concentrated, and where more support and more action is still needed. When you have, in particular in Africa, and even before COVID-19, what we saw was a trend where adolescent girls and young women in particular were getting infected with HIV. And that creates obviously a burden not only for themselves, but for the education system and for the society and the economy in the future. So this is why we want to put much more emphasis on prevention in the years to come, in particularly towards the most vulnerable populations. So World AIDS Day is obviously a very important moment for the world to every year take stock. And taking stock means realizing what has been achieved. And as I said, a lot has been achieved, and the world needs to recognize and learn some lessons from the fight against HIV when it comes to fighting COVID-19. There is so much that we need to learn. Taking stock means also, in the current context, being acutely aware of how much COVID-19 can wipe out 20 years of progress, and how important it is that we protect that progress, because it can be deleted just in a few months. And taking stock means also realizing what remains to be done. And the world has decided and has made commitment to end HIV as a global health threat in 2030. It is in 8 years, not too far away. We are not done yet. And we need to fight COVID, but we should not forget the pandemics, the old pandemics that perhaps we tend to believe have disappeared and have not disappeared and are still killing people and still infecting people, including young people, as we speak. So it's a day really to take stock and recommit to ending HIV as a global health threat and fighting it until we win.
Well, certainly there is some evidence that people who are very immunosuppressed, whether that's from HIV, from taking cancer medicines, from immunosuppressive medicines, that they have a much more difficult time mounting a full and robust immune system, developing those fighting antibodies and ensuring that they can fight off and ward off new infections. And it also means that the vaccines, when given, may not be as powerful in terms of developing those antibodies. So for anyone who is living with HIV, being on antiretroviral treatment means that their immune system is going to be maintained strong, because the virus of HIV actually attacks the immune system. So by being on treatment, we can reduce that effect of immunosuppression. And I think also people living with HIV and other immunosuppressed people should be first in line for getting the COVID vaccines. And they should have a third dose if they need one, if they haven't mounted a very good immune response. There have been some cases where some of the variants have been noted to be developed in people who do not have robust immune system, because they are unable to clear that virus. And once in the body, the virus can then change. And that's where the mutations and the variants do develop. But in the case of Omicron, I think there's just simply speculation. We have no idea if this is the case. And currently what we do know, at least from the reports from out of Botswana and South Africa, there is no link to people living with HIV. And so I think also it would be dangerous for us to link living with HIV and variants, because that could be further stigmatizing, and people living with HIV have been stigmatized for years. And I think we have to base all of our evidence on science and do our best to get people the medicines that they need and ensure there's no disruptions to their antiretrovirals. Well, I believe it's absolutely possible. And the only way to do that, though, is if we have a recommitment to ending AIDS as a public health threat by 2030, to recommit funding that ministries of health, ministries of finance, governments need to respond to their epidemics in their countries and provide adequate services and finances to do this. And we need to follow the best science and ensure that everyone has access to testing, prevention, and treatment. And some exciting new prevention modalities are really on the cusp of being able to come out to different parts of the world. And if we use some of these new technologies, long-acting preventive antiretrovirals, we might be able to actually to really nip this in the bud and get control of this global epidemic that we've been fighting for 40 years. So I have to believe that we can do this, but it needs concerted effort, and it can't fall victim to the next big problem. Because if we move on to fighting newer diseases and we don't do and finish the business of HIV, we will certainly see HIV come back, and we will certainly see the impact on economies and shorter lives lived that we saw in the 80s and the 90s, because viruses do their work, and we know everybody now understands what happens with viruses. There needs to be control, there needs to be treatment, there needs to eventually be a vaccine. Otherwise, viruses will continue to live with us in our world. You know, I wonder this as well, but I think we have to look at what's been happening in 2020. Certainly the know-how, the science, the community leaders, the doctors who have been working on HIV for the last 40 years pivoted and quickly repurposed and worked for COVID. So I think we can look at the systems that were set up for HIV, including the vaccine platforms, including the community-based delivery of services, including the supply chains in low and middle income countries, and even the PCR platforms for COVID tests. They all got set up because HIV know-how, innovations, and materials were in countries. So in many ways, I think the COVID response has really benefited from the years of HIV investments. I think right now it's time, and certainly when we are faced with a pandemic that's life-threatening. I mean, we already know we have over 5 million people who've died of COVID. We absolutely need to be able to address that urgently. So I think it was the right thing to do in 2020. And as we move forward into 2021 and beyond to 2030, we have to catch up. We have to restart all those essential health services. We have to balance being able to provide services for people living with HIV as well as protect them from COVID, and start to build a primary care and health systems that can deliver this for the longevity. So in many ways, I think what happened was very natural. And I also think that those people who've dedicated their lives to HIV are now dedicating their lives to HIV and COVID and other infections. So in many ways, I think the HIV community is very happy to have served being able to address this major pandemic that's happening right now with COVID. Currently, right now, mid-2021, we have nearly 38 million people living with HIV. 28 million of those are on antiretroviral. And in the year 2020, we actually still had 1.5 million new infections and nearly 700,000 deaths. Those two latter numbers, the deaths and the new infections, are still too high. And to be able to end AIDS as a public health threat, we have to reduce both the new infections and those people who are dying of AIDS-related causes. This is a very complex question, but for HIV, there are different subtypes. There are different mutations that have occurred, and I'm not sure that it has mutated in a way to be able to control more easily. But what we've seen is And what we've learned through the years of research and science with HIV and the clinical care, that the virus does learn to evade the drugs that is used to stop its replication in the body. And so what we monitor for, or what we look for, are antiretrovirals, or the drugs that treat HIV that are robust, that do not cause resistance and that the virus does not change to avoid or evade the drug. And we have seen over the time that we have been able to have a good pipeline of drugs that maintain their ability to act on HIV and to keep what we call the viral load, or the amount of virus in the blood, suppressed and at a level that is low enough that it's not going to be able to be shared with either sexual partners or between a mother and a child during childbirth. So I think that there are mutations that occur, but then there are ways to look for those mutations and to have drugs that can address them. WHO just a few days ago put out our annual report around HIV drug resistance. And in there, we've seen that more countries are now monitoring for HIV drug resistance, and that the typical patterns of drug resistance are what we are expecting. And over the last 2 years, we've changed our common first-line antiretroviral therapy for all people in the world to something that is robust and can address and reduce resistance. So in many ways, surveillance, the kinds of things you hear about for COVID, is what's been going on for years for HIV. And that surveillance helps us to change the regimens and the drugs and the therapeutics to be able to address the virus and treat the person who has the virus. And that's very similar approach that's being taken with COVID, that if you hear right now there are new variants, those who are developing vaccines, those who are developing therapeutics, are looking to see how they can modify their therapeutic or vaccine to be able to remain effective against the COVID virus. We have multiple strategies in the world to be able to address HIV and AIDS. For WHO, we are in the midst of updating what we call our global health sector strategies for HIV, for hepatitis, and for STIs that will take us from 2022 to 2030. In those strategies, we're using approaches such as having the best science, the best recommendations for nations, the best drugs, the best prevention methods, as well as testing methods that put testing in the hands of a person, self-testing. We are also working to ensure that there's a reduction of stigma and discrimination for those people who are most likely to be living with HIV. It's important that we have our services in the communities around the needs where people are living with HIV. And certainly we're moving forward that we're going to monitor this and have data to come back and say, if we have gaps in certain countries, how do we readdress those? We're all working under global targets of reaching 95% of people in the world knowing their status, 95% of those people on treatment, and 95% of those with a viral suppression. And we already have 1 or 2 countries ready to make those targets. And if we can have more countries around the world make those targets, then I think we really can be close to ending AIDS as a public health threat by 2030.